Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone, good evening and welcome to Diabetic Educator Society Voice number 6. Thank you all for joining us today for this exciting webinar titled Smarter Diabetes Care Integrating Lifestyle, CGM and AI. My name is Rula Fakhri. I am a clinical dietitian and certified diabetic educator at NMC Hospital Abu Dhabi. It's my pleasure to welcome you all, and I am delighted to be moderating today's session. So, before we begin, I would like to sincerely thank Abbott Diabetes Care for sponsoring today's webinar and the choice for organizing today's event. Thank you so much for their support and for this important educational initiative. Today's webinar is a CME accredited by DHA, and all the participants will receive their certificate, inshallah, by tomorrow on registered email. And if you have any question, please submit them to the chat box. Without further delay, I would like to, it's my pleasure to introduce our first speaker, Dr. El-Amin Abdul Qadir. Dr. Amin, he is a consultant endocrinologist, associate professor of endocrinology at Mohammed bin Rashid University of Medicine and Health Science in Dubai. Dr. Amin, he will be speaking about CGM in type 2 diabetes, a new era of personalized diabetes care. Dr. Amin, we are very happy to have you with us and thank you for joining. The floor is yours.
Thank you very much, Ms. Rula, for the kind introduction, and I extend the thanks to the Diabetes Educator Society for the very generous invitation to be among them. This is a community where I really feel belong to, and I'm very delighted to be part of this activity and many activities to come in future, inshallah. I've been given the task to discuss the continuous glucose monitoring system in type 2 diabetes. And it's a truly challenging task to discuss the CGMS in a diabetes educator and clinical dietitians community. However, I'll do my best to make it as simple, practical, with a couple of grab points to be taken home at the end of the day. And I've added to the title that continuous glucose monitoring in type 2 diabetes from numbers to clinical reasoning. And I'll tell you why during the coming 25 to 30 minutes from now. Without any further ado, what I'll be doing in the coming 25 to 30 minutes is to go quickly through the concepts and metrics of continuous glucose monitoring, and then how practically do we need to look into the reports that comes from the CGMS, and what do we have in terms of evidence in hand regarding the type 2 diabetes management using the continuous glucose monitoring system. And they'll end up with a couple of quotes from the international guidelines. What should we do regarding CGMS in type 2 diabetes? By any means, I'm not here to say that HbA1c is bad. HbA1c remains a very useful and essential tool of management in people with type 1, type 2, and other types of diabetes. However, it's just not enough to rely on in day-to-day practice, especially when we need to have a tighter glycemic control and a safer titration without higher risk of hypoglycemia. So whenever I criticize HbA1c, I just point to that we have a better tools, a better day-to-day reports that based on it we will have an informed plan or action that will just fulfill the needs of this day or tomorrow or the day after. While the HbA1c tells us what had happened in the past 3 months with a special focus on the last month. So there is a big difference between the HbA1c that gives us the average of what has happened in the past 3 months and any device that reports currently how your blood your body is reacting towards the hyper or hypoglycemia in terms of diabetes management. So the benefits of HbA1c are quite remarkable. It's readily available to each and every healthcare provider in the world almost, and it will remain to be essential in the coming couple of decades because the availability of the newer devices are expanding, are growing remarkably, but it will take some time to be a standard of care to each and every healthcare provider institute. However, the HbA1c, despite this huge body of benefit and positive outcomes, there is a couple of drawbacks that we need to take care of. Probably you're all aware that HbA1c might give us a false positive, false negative results. False positive, especially if there is vitamin B12 deficiency, iron deficiency anemia, and post-splenectomized patients. And as you all know, that HbA1c is fully relying on the glycation of the RBCs. So anything interferes with the RBCs lifespan, where the splenectomy story comes through, that because we all know that the spleen is a graveyard of the RBCs, the older RBCs. So when we don't have enough space to uptake the older RBCs, then the newer generation, the older generations will remain circulating and giving us a falsely positive glycated number of RBCs. However, we can have also a false negative or false low HbA1c in case of hemoglobinopathies. And this part of the world where we're practicing in the Middle East and North Africa and Central Africa, the hemoglobinopathy traits and anemias are quite prevalent. So we need to be careful when we deal with a patient with G6PD or sickle cell anemia or the advanced thalassemia, that we should not fully rely on HbA1c because the lifespan of the RBCs is not as normal as when the devices or the test has been standardized. So HbA1c remains an excellent prognostic variable, but it's a poor titration instrument, and those two roles has to be clearly distinguished from each other. We've mentioned that it covers 3 months backwards, and it's fully dependent on the RBC's health and lifespan. And there might be also a racial variation in the glycation process. So it might just be not very accurate in some of the African tribes, for example. And it's not very well understood so far, but this has to be kept in mind when we have discrepancy between the HbA1c and the day-to-day glycemic variables. Moreover, we've mentioned that HbA1c gives us the average of the glycemic parameters over the past 2.5 to 3 months. So those are 3 patients, and this is very commonly presented in all the continuous glucose monitoring presentations, that we need to be careful that different patients will come up with more or less the same HbA1c. However, their glycemic patterns were completely different from each other. The first one is HbA1c is 7%, but his blood glucose has always been in the green zone, and the green zone is between 70 milligrams and 180 milligrams per deciliter. So this patient is in a safe zone in terms of the day-to-day glycemic parameters, and he is in a safe zone regarding the HbA1c. The second patient, his HbA1c is still 7, but we know that the HbA1c is the mean of readings. Going back to school days, and we came to know that the mean is the summation of each and every reading divided by the number of readings. So we will count this plus this plus this plus this plus this divided by the number of readings. So the mean again will come here in the green zone. So it will deceivingly gives us the HbA1c of 7, which is the mean, and it's right. But we had the blind spots, the many hypers and many significant hypos that would be even more scary to be missed, especially in the late time of the night or the late hours of the night and early morning hours, where this nocturnal hypoglycemia might be very, very crucial. Sorry. And the third patient is also having the mean frequent trivial hypers and near hypos at some points. So again, this near hypos has to be attended, and this minor hypers has to be attended as well. Without having this day-to-day reporting of the continuous glucose monitoring, we will never be able to attain these hypers during the day. The patient will come to you after 3 to 4 months and tell him, thumbs up, your HbA1c is perfect. Continue what you've been doing and see you in 3 to 4 months down the line. And with that, we'll be missing these blind spots, which might be devastating at some point in time. When we started having the continuous glucose monitoring reports, we started seeing these type of figures, which tells us how many, what's the percentage of the time of the day or the week that the patient were living with normal glycemic indices, how many percentage in hyperglycemia, how many percentage of severe hyperglycemia in the dark yellow side, and how many percentage of hypo and severe hypoglycemia on the other side. So this patient might relatively be in a safe zone. 72% of the total time of the day he has been living with normal glycemic parameters, while 24% is sustained high glycemic indices, which is more than 180, but less than 250. And somewhere around maybe 5% here or 8% with severe hyperglycemia, with very minimal hypoglycemia, which is quite warranted parameter. While the second patient, he sustained almost 10% of the day living with hypoglycemia and somewhere around 30% of the day with hyperglycemia and only 60% with normoglycemic parameters. So the HbA1c might be more or less the same in both patients, but absolutely there is an action to be taken here, and action will be to correct the hyperglycemia. While the action here, again, it's 7%, the first action will be to avoid or to minimize the hypoglycemia first, and then how to control the 30% of hyperglycemia. So it even gave us reasoning of the next step. It's not only that HbA1c is controlled. No, now we know there is some point in time the patient is living with hyper. We need to up titrate your medication. There is some point with severe hypo. You need to be very careful. And this is the first step to be taken whenever you look at an AGP or the ambulatory glucose profile report. Okay, so again, from numbers to clinical reasoning, we started having quite various types or styles or products of continuous glucose monitoring, but they all have the same concept. With a microfilament, they test the interstitial glycemic parameters. So whatever glucose that oozed out of these capillaries came in this interstitial, the fat in the subcutaneous area, then the microfilament will measure the glucose concentration in this area, which in fact gives us the reasoning of why there is a bit of delay of the glycemic parameters compared to the central capillary glucose testing, because there is a transition between the capillaries and going out to the interstitial fluid. And it also explains that there is most of the time, there is the lower glycemic parameters in the CGMS, mildly lower, because the fat cells here, they will uptake part of this glucose because the glucose came out to feed the tissues around it. It didn't come out to just be available to the microfilament. It came out to feed these fat cells. So some of the glucose will be taken up by the fat cells. So there is always a minor difference between the capillary and the interstitial glycemic parameters. And we have now real-time continuous glucose monitoring. We refer to it as RT CGM. We have intermittent scan CGM. We refer to it as ISCGM. And we have the professional CGM, which is a blinded one, and it's not used in clinical practice as much as in clinical research and behavioral changes. This is how the AGP report, is ambulatory glucose profile report, will be seen. It's quite familiar to so many of us. It gives you how many days that the patient has put the sensor at the time of the continuous glucose monitoring was active. And then the targets of blood glucose, how many percent that we need the patient to be in hypo, severe hypo, or hyper or severe hyper. Not we need the patient, we accept these parameters because, of course, we will not be in a position to need a hypoglycemia, but we may accept somewhere around 5% in some categories, youngsters with low risk of severe hypoglycemia, low risk of fall. But in older population, this hypoglycemia should be minimized to 1% or even none if in case of severe hypoglycemia as well. So this is quite common, and probably most of us are seeing it on day-to-day business, and it might have become a habitual thing. When you just have a look in few seconds, you will know where do you need to take an action. Furthermore, you will have even more details about the daily patterns of the glycemia and the timing of the hypoglycemia and how bad the hypoglycemia was. And here, the darkest line in the middle is the mean glycemic parameters. But we need to be careful about even the confidence interval, that this patient had times where the blood glucose shooted more than 400 or probably 450 milligrams per deciliter. So we shouldn't only focus on the median or the mean line. We shouldn't focus on even the early confidence interval, but we need to take the whole thing and probably upon the discussion, our colleagues in the community, the diabetes educators, might touch on that as well. So we need to have the overall holistic picture when we look into the AGP report, and we go into details of the CGMS. Another beautiful addition that we can have a personalized reporting, but as mentioned earlier, probably the patient is pregnant, where we need a more tighter glycemic control. The patient is older or senior citizen, we may need a less stringent glycemic parameters with more focus of avoidance of hypoglycemia. So we just play with the target ranges, and then the device will read the new norms. So 70, less than 70 is quite okay in youngsters, but we need it for someone who's 80 or 90 years of age to be 80, the lower cutoff to be 80, 85. Then we adjust it and the device will read it as is. Less than 80 is hypoglycemia in the new norms of the device. So between 70 milligrams and 180 milligrams is the green zone I've mentioned, and this is called the time in range, and we need it to be as much as possible more than 70%. The higher, the better. And 70% constitutes around 16 or 17 hours across the time lines of the day. So is this the good glycemic control? Earlier days, we used to say, yes, this is the good glycemic control, but now we have so many parameters, we have so many informing and empowering parameters, where we have the time below range and the percentage, which is the time below range and the percentage of the time during the day, the time above range, and we always need to start with the safety. So whenever you need to take an action, start with the hypoglycemia parameters first and then correct the hyperglycemia. So this green zone is part of the glycemic control. It's not the whole good glycemic control that we used to say in earlier days. So we need to have a good time in range, which is more than 70%. We need to have the least time below range, which is always red. We need to have the time above range minimized as much as possible. And we need to have a sort of steady and stable glycemic variation or glycemic parameters during the day, because even the extremes of glycemic variation are associated with adverse cardiovascular insults. And in the end, we need to have a reasonable HbA1c, and we need to have a reasonable glucose management indicator, which is the calculated type of HbA1c using the device. So this, instead of being the first thing to look into when we used to take care of patients with living with diabetes, now it's the item that we come back to after we make sure every tick has been allocated to other parameters, and then we come back to the HbA1c or the GMI. Another very useful strength point, it shows that those devices shows us how fast the glucose is going up or how fast it's going down, and whether we need to take an immediate action or sort of long-term action. And this is, again, is very useful day-to-day trick. And yes, there is some interference artifacts, but most of them has been reported with the older type of continuous glucose monitoring devices. Recently, the newer ones, they have managed to minimize these artifacts and the influence of them on the newer devices. One of the most important points, and in an area that's very close to my heart and practice and studies, the compression, whether the skin compression or skin folds or the fat contents on the sensor might give you false negative or false low results. Sorry. And the patients has to be empowered with that and informed, instead of they themselves realize that and come to you saying that your device is not reading as good as the POCT is reading. So especially patients who have lost weight, whether using medications or surgery, where they will have quite a big amount of redundant skin, compression might be very easy, especially in the nocturnal time where the patients are sleeping. So the potential of false low glycemic parameters is quite high, and this has to be well informed and probably replacing or relocating the position of the sensor to another safer place. So looking into the AGP report, this is probably known to everyone. We've just mentioned them in the AGP report, and there are several parameters. Probably we can revisit them in future, but we should never intensify hyperglycemia before having explained the hypoglycemia and having taken an action to correct the hypoglycemia, and we've mentioned that earlier. So again, in all the CGMS presentations, we need to have sort of hands-on cases, but now it's webinar-on presentations or the cases, if we can say. This gentleman is living with HbA1c of 7, while he's having the time in range around 55%, time below range around 88%, which is quite not acceptable. And the coefficient variation, which is the glucose variability, is 44%. So those three parameters has to be corrected. And here it tells you that in early morning of the day or early hours of the day, there is the risk of hypoglycemia or hypoglycemia, and there is surge of hyperglycemia at midday and late in the day. So we need to attend the hypoglycemia here first, the hypoglycemia here at the mid of the day or in the afternoon hours, and then we need to correct the hyperglycemia afterwards. So the first point is to protect from hypoglycemia, because we are having a consistent pattern of hypoglycemia early time early dawn time, and before sunset. So this, if the patient is on prandial insulin, this has to be corrected here. If he is on basal insulin, this has to be adjusted. If the patient is missing the evening meal or the dinner, then this has to be replaced by a snack or bedtime snack or so. Then identify the source of variability, and then you can address the hyperglycemia afterwards. So the lower average achieved by treating the hyperglycemia for hypoglycemia is not a better control. And again, this is the mean of the variations, or we should not rely on this 7% only. Another patient is having good fasting glucose, that when he wakes up, the blood glucose is somewhere around, let's say, 100, 110, 120. But between 1 and 4, between the first hour of the day until the just pre-dawn time, he's having again consistent and persistent hypoglycemia. Time below range is 9% here, and while the rest of the day is quite acceptable. A bit of dip of surge here, but quite acceptable the rest of the day. Here we need to focus on the long-acting insulin, minimize it, add the bedtime snack, avoid exercise in the late night hours. And so this informed decision will only tackle the hypoglycemia, and we will not touch this. Maybe after correcting the hypoglycemia, avoiding the overreaction, maybe even the hyperglycemia in the middle of the day will be corrected, and nothing else other than reducing the basal insulin here. And we've mentioned that in details. This person, again, is having a reasonable fasting blood glucose, but persistent postprandial hyperglycemia, no hypoglycemia. So here, straightforward, this patient needs either to minimize the carbs in the meal time or add prandial insulin to guard against these hypers. So nothing to be worried about in the hypo side in this particular case. Sorry. So if a patient is a high risk where we don't need a very stringent glycemic control, then we don't need the reasonable blood glucose to be all the time. Our main aim will be to avoid the strenuous hypoglycemia events here, because it might be devastating, associated with risk of fall, cardiovascular insults, and intracranial bleeding and other stuff. So the main culprit here will be the avoidance of hypoglycemia and downsizing the intervention, other than up titration of the medication despite the HbA1c of being normal. Okay, so with that, we've just paved the road, and probably we've taken quite some time, but this is quite important to understand from where we're coming towards type 1 diabetes evidence and, of course, type 2 diabetes evidence. And the journey of the continuous glucose monitoring have started probably 20 plus years ago, where we used to have the blinded 3 days CGM, and blinded means that only the healthcare provider will be able to read the results. And we've come a long way, getting more evidence in both type 1 and type 2 diabetes, and reaching a point where many international society or professional guidelines have recommended using the CGM, not only for type 1 diabetes, not only for type 2 diabetes on insulin, even a less risk of hypoglycemia category are also being endorsed in the guidelines, and we'll come to that in a minute. So for type 1, we've got quite a good number of evidence that concurs lower risk of hypoglycemia, a better glycemic control, and more duration of time in range in people with type 1 diabetes. And based on that, we've got the FDA approval and other entities approval quite early. While for type 2 diabetes, we started having the earlier evidence by just few years down the line, where we started having the safety indices using the data from REPLACE, where they studied the patients with type 2 diabetes on multiple daily injections of insulin. And the main aim was just to assess the risk of hypoglycemia adjustment in those people at multiple daily injections of insulin. Then the diamond type 2 diabetes, we have another diamond for type 1 and diamond T2D for type 2 diabetes, again on MDI, and it has shown that it's the having the CGM is associated with a better glycemic control at the end of the duration of the study. Just a couple of years ago, we've had a mobile study where they investigated patients with type 2 diabetes and only on basal insulin. And that was a breakthrough to say that, yes, people with type 2 diabetes on basal insulin did benefit from the CGM by having more time in range and having quite significant less severe hypoglycemia indices until we got just 2 years ago or 3 years ago that the what's called the immediate study where they evaluated patients on living with type 2 diabetes on no insulin at all, on just behavioral intervention and a proper structured education. And again, having only the CGM intervention managed to increase the time in range duration and improve the HbA1c parameters at the end of the study. So it's a very elegant and very steady more step by step towards positivity in just 5 years from something that not well thought of. Can we use the CGM in type 2 diabetes until we got it that yes, we can use it with positive outcome even if the patient is not on insulin. So without going into details of it, that replace study have managed to say that the patient had less time below range, less time of hypoglycemia, and less time of severe hypoglycemia, and this has been statistically significant. So HbA1c alone would have labeled this trial as negative because the HbA1c difference was negative in this study. So we cannot just rely on the HbA1c here, while we have a more important, a more significant outcome that is clinically significant and statistically significant, less incidences of hypoglycemia. Again, a pitfall of HbA1c. Diamond T2D, again, the HbA1c was significant here, but the glycemic control was better. So there is an edge of having CGM in improving the risk of hypoglycemia and in controlling the glycemic control. The mobile study on basal insulin only, a better time above range and a better time in range with a better overall glycemic control. Immediate study, again, this is patients on no insulin at all, a better time at range or time above range, and better time in range with the time in range is in range better by almost 10% compared to people on not on CGM comparator. So this have led the international guidelines to move very swiftly from just a few years down the line that there is no evidence to support use of CGM in type 2 diabetes. And here I quote that the American Diabetes Association guidelines just published a couple of months ago that the use of CGM is recommended at diabetes onset and at any time thereafter for adults with diabetes who are on insulin therapy, on non-insulin therapy that can cause hypoglycemia, including sulfonylureas, and on any diabetes treatment where CGM helps in management. So it's a very wide open door that in a wider range of type 2 diabetes, we can use the CGM to get a better informed decision and a better structured way of managing people with type 2 diabetes. So it's highly recommended in patients with type 2 diabetes on insulin therapy, even category C recommendation in non-insulin therapy causing hypoglycemia, and category C in non-insulin patients where the CGM might help. So see, the being on basal insulin or non-insulin causing the sulfonylureas or any other medications that does not include the sulfonylurea, but yet the CGM might be helpful. Again, it's highly recommended. We've mentioned the ADA, and it's the broadest inclusion to CGM in type 2 diabetes. ACE guidelines, it's a little bit older one, 2, 3 years backwards. Again, the type 2 diabetes on insulin or at high risk of hypoglycemia may warrant being on the CGM. Nice guidelines from the United Kingdoms, and we know this is very cost-effective type guidelines. Still, they endorsed the CGM in type 2 diabetes, but in more selected group of patients where they need to be on MDI plus the specific hypoglycemia and monitoring is needed to support the decision of having this CGM. ATTD guidelines, again, standardized targets. Whenever you need those targets, then you can introduce the CGM. So there is a very strong divergence. Is no longer the efficacy of those medications or how efficacious those medications are, but what's the risk of hypoglycemia, and then the eligibility of reimbursement and implementation is the hurdle from prescribing or the CGMs. So the efficacy of CGM in type 2 diabetes is already well acquainted, and then how feasible and attainable having the CGM in people with type 2 diabetes. We've mentioned the ADA and we've mentioned the ACE guidelines and NICE guidelines. So just for the sake of the time, even Diabetes Canada, again, they supported the use of type 2 diabetes on insulin to be on CGM. Even non-insulin, it's not routine, but intermittent or episodic use is positioned as reasonable. So whenever you need to have an informed decision, then you can have the CGM on board. In our guidelines here, we've supported that the CGM should be available for people with type 2 diabetes on multiple daily injections of insulin. And this a living document might be updated in the very near future. So now the pragmatic clinical framework from different guidelines that the highest priority to people with type 2 diabetes on insulin or high risk of hypoglycemia or severe glycemic variability or very poor glycemic control where we need to have an informed decision. It's strongly considered in patients on basal insulin alone, even if the HbA1c is just above target, and treatment decision is uncertain, again, another indication. And then we can say that the majority of the guidelines are saying that if the patient is on type 2 and at risk of hypoglycemia, whether the sulfonylurea or senior citizens or CKD or pregnant ladies, then we may consider the CGM as well. So now the right question is no longer, does this CGM, does this patient of type 2 diabetes qualify CGM or not? The question now, will the CGM have information that changes or change your management in the coming few days? So this is a completely different era, and as we've discussed earlier, this swift movement from not having CGM in people type 2 diabetes to a very wide range of patients that may qualify being on type 2 diabetes. And I'll conclude with that, and I'm happy to answer any questions in the Q&A session. Thank you very much.
Thank you so much, Dr. Al-Amin, for this excellent and insightful presentation and for highlighting how CGM is transforming diabetes care and supporting more personalized management for type 2 diabetes. Thank you so much. It was a very informative lecture. So I would like to remind you to scan the QR code and invite all of you to register for second Emirates Diabetes Educator Society conference that will be in Dubai starting October 31st and 1st of November at Sheraton Grand. So don't miss this opportunity, joining us for learning, networking, and sharing the latest update in diabetes education. We have reached so far more than 245 participants. So please submit your question to the chat box so we address them with the panel discussion. Now, we will move to the next speaker. I would like to introduce Ms. Fatin Bayato. She is a senior clinical dietitian and certified diabetic educator at Health Plus Diabetes and Endocrinology Center in Abu Dhabi. She has American board certified in lifestyle medicine professional. Ms. Fatin, she will be speaking about improving diabetes non-compliance outcome via lifestyle intervention. Ms. Fatin, we are very happy to have you with us. The floor is yours.
Good evening, and thank you all for joining us again for another exciting session by the DES Voice, brought to you by the Emirates Diabetes Educators Society. And today it is sponsored by Abbott Diabetes Care. It is always a pleasure to share this seminar among other colleagues and friends of mine, Dr. El Amin, consultant endocrinologist, and president of the Diabetes Educator herself, Ms. Zainab Al Abadli. So today I'll be talking to you about improving diabetes non-compliance outcomes through lifestyle interventions. I hope by the end of this 30-minute session, you will have some understanding about the relationship between nutrition, exercise, and behavior changes that can all interact to prevent and even treat chronic diseases. I want you to examine the biological links between our daily habits and how it affects the chronic disease progression itself. I hope by the end of this webinar, you can be able somehow to design a basic personalized lifestyle intervention plan tailored to your patient needs. And most importantly, to utilize the behavior modification tools to help our patients build sustainable, healthy habits. Non-adherence remains, and it will always be a significant challenge in chronic disease management. Non-compliance or non-adherence is a very common word that we use when we document our notes. And unfortunately, the number of those patients are not few. We all know what poor adherence can lead to when it comes to adverse patient outcomes. This can include, but it's not limited to, the disease progression itself, the increased morbidity for patients, how it affects their quality of life. It will be definitely reduced. The higher admission for hospitals, consequently, it comes with higher medical costs and mortality. In 2002, the World Health Organization has estimated that around 50% of patients who are recognized as having chronic disease, they are considered as non-adherent. More than 20 years later, in Sheena Patil, as the author of this review, Sheena Patil and her other colleagues, they have also demonstrated that this percentage did not change that much. So non-adherence remains a complication, and it is somehow influenced by multiple factors, including the patient themselves. It can be related to medication, to the cost, to the side effect, and even the healthcare system itself. So this means that improving diabetes outcomes remains a key, especially when we think about diabetes in particular as a chronic progressive disease that patients will struggle with on a daily routine care. So this demands support in different things. We need to customize lifestyle strategies. We need to give them more interventions targeting their nutrition, their diet plans, addressing physical activity, and mostly focusing on behavioral change. We often hear the word lifestyle, but what does really lifestyle mean? Is it such a trendy thing that patients keep using, or us as healthcare provider, we tell our patients to? So what is basically lifestyle medicine? Lifestyle medicine is actually a medical specialty that uses therapeutic lifestyle interventions as a primary modality to treat chronic diseases, not only limited to diabetes, but to other chronic conditions. Now, what makes lifestyle therapy or lifestyle intervention distinct from other fields is that it targets to treat the cause of the problem. of most of our modern diseases. And when you pause for a second and think, most of our modern diseases are actually caused by our lifestyle, how we treat ourselves, do we sleep well, how we deal with the stress levels that we have. So it comes with no surprise that lifestyle changes must be part of the cure. Also, what makes lifestyle medicine a bit different from other modalities is that it is always prescribed as the first and most important therapy for disease treatment, in addition to other medication. Now, when you look at the literature, you would see tremendous amount of research supporting the benefits of lifestyle interventions. But for the sake of time, I will only share the key supporting studies that target diabetes. This is a randomized controlled trial where the researchers have grouped individuals with type 2 diabetes into two randomly assigned groups. One group had the low-fat vegan diet, and the other group made them to follow the American Diabetes Association diet. So they have evaluated the participants at baseline and at 22 weeks. The result that the researchers found that those who followed the plant-based dietary patterns had an improvement in their HbA1c by 1.23%. This reflects as a 15% relative reduction from baseline compared to those who followed the ADA diet group. Another supporting study is a statement from the American College of Lifestyle Medicine, and it is a review of literature that found the remission of type 2 diabetes is feasible if lifestyle interventions are applied. And they have also found that dietary patterns appears to play the biggest significant role in that remission. Even the American Diabetes Association and the latest diabetes care or standards of care in diabetes published in 2026 clearly mentions that lifestyle management is a fundamental aspect when it comes to diabetes care and when it comes to diabetes self-management. Likewise, the Endocrine Society, in their clinical practice guidelines, they have stated that in patients who are aged 65 years and older with diabetes and who can move, they recommend lifestyle modification for the treatment of their hyperglycemia. And so now we have seen how important it is to implement the lifestyle medicine or the lifestyle intervention. So what does lifestyle medicine include? So it mainly includes 6 pillars. And for the sake of time, I'll be focusing on the first 2, the nutrition and the physical activity, and how we can integrate the behavioral change between these 2 pillars. So the first pillar is nutrition. And let me just elaborate a bit more on that part, because I want you, as an audience, as a healthcare professionals, to understand why does our relationship with food matter. So when you think about it, the topic of food is almost discussed every day. Every day you think what I'm going to have for breakfast, what I'm going to have for lunch, for dinner, what should I cook for today? If you go to work, you hear people talking about food. You open your mobile, you see an ad for food, or you see a chef cooking a fancy meal. Even today in our Zoom call, we are actually discussing nutrition and food. But why is that so important when it comes in managing diabetes? Because it is so important for us to understand and for the patient themselves to know exactly why do we eat? What motivates us to eat in the first place? Do we eat because of boredom? Do we eat because of hunger? Or do we eat because of sadness, of depression? Do we eat to celebrate things? So these things and this information has to be addressed to patients. And so when you think about it, food can be a form of love, or it can be a form of abuse to our bodies. The relationship of food is quite complex. It does not only involve actually eating it. It has a different process from shopping, planning, storing, goal setting, preparing, cooking, etc. Food also can serve as a symbol of our value system. The things that you value the most, the things maybe you feel proud of. You would see someone coming to work and walking proudly. Guess what? I've been off sugar for the past 10 days. Or someone might feel a bit guilty after eating a heavy meal, maybe late in the evening. So it serves as a different systems in our lives. Food actually can serve as a form of kindness. If you and your friend are out in a cafe, she offers to pick the bill. So how kind of that of her? Food also serves as a characteristic that people are known for. Oh, here comes my friend who only loves burger. Or now I'm going to meet my friend who's going gluten-free, for example. So you label people by what they prefer and what they love when it comes to food. And as you can see, here we have in this presentation people attending from the whole GCC region. So food is considered a universal connector. It is somehow fundamentally tied to our emotions. How many times you tried to convince one of your patients to stop eating that particular food or to stop drinking that particular drink? And they would tell you, it just reminds me of my mom, or it just reminds me of a specific tradition we used to do at our house. So food is closely tied to that emotions. And even food can serve as an empowerment. For a lot of patients, we have heard them telling us that multiple times, that I feel I deserve a good meal after I come back from work. I do deserve that burger or that French fries or that brownies. I've been working for 8 or 10 hours straight. And so unconsciously, it becomes to a lot of people that the only reward system that they have is related to food. And because of that, one thing actually remains constant. We don't only eat because of a biological need or of a cellular level. We also eat due to a psychological need. Why I've talked about all of those things? Because I want you to picture this. A patient comes to you who has a diagnosis of diabetes, and he starts talking to you about, tell me more about the factors that affect diabetes. So as far as we know, we have more than even 42 factors affecting that. So imagine for a moment, you would be that healthcare provider that you will tell him this news, that food, the thing that you love the most, the thing that is tied to all that emotions and memories and celebrations and all of that unconscious reward system, this will have the biggest impact on your blood sugar. And you need to change that. So do you think that patient will accept that advice freely, completely? I tell you from my experience, it's quite hard and it takes time. So when it comes to nutrition and when we discuss the diet itself for diabetic patients, my approach is to simplify as much as possible. So when they ask about what is the best diet for diabetes, simply when you go to open any nutritional book and you look for the diet definition, it's simply the foods habitually eaten by an individual or group. Those foods should include all the three major macronutrients, including other also micronutrients. And even this is supported by the US Department of Agriculture and their latest dietary guidelines, where they have emphasized simplicity. They have emphasized people to eat whole, nutrient-dense food. Even when it comes to the highly processed food, added sugar or artificial additives, they didn't advise to completely avoid it, but there was a proper guidance on how to limit the consumption of these processed food. And speaking of simplicity, if a patient would come to you and you would tell them you need to consume less than 48 grams of sugar per day, they will not understand that. So you need to simplify it, and you need to give them an example that they understand, they can digest. So simply you tell them a teaspoon, what is allowed for you compared to teaspoons, as per the WHO or the American Heart Association. And so when it comes to nutrition, the focus should be basically on metabolic individuality. Not everyone can follow the same advice. The priority should be to protein quality, with the end focus is to have a regulated blood sugar. But despite all of this simplicity, you would still see patients having unhealthy lifestyle, continue doing those unhealthy lifestyles even after the medical problem is well diagnosed. And we have seen that, and we still continue to see that in our clinics. This brings me to a very important thing. If you want to change your lifestyle, then the health behavior change is a must. In other words, health behavior change is the foundation of lifestyle change. It is always easier to say it than to actually do it. Why? Because I tell you from experience, change is very difficult. When a patient comes to you having diabetes for the past 10 or 15 days, been following a specific dietary habits for more than 30, 40 years, do you expect that you would change those habits in a 10 or 15 or even 20 minutes consultation from the first or the second or even the third session? It takes time. And this, what the wheel of change explain it. For us as healthcare professionals, we need to understand where does our patient stand in the wheel of change. And this is what the trans-theoretical model explains. It simply recognizes that behavior change is a process that needs time, and it goes through a series of stages in which different interventions are more effective. So it's a process and it needs time. And it's also important to recognize that behavior change is individualized. We should not expect everyone to move through the wheel of change at the same pace compared to other patients. It is individualized. Patient, you might see them skip stages, move quickly between one and another, or perhaps stay longer in a specific period of time. Now, why I am discussing this with you? Because as a healthcare provider, you should be able to distinguish at what stage your patient is. Because this is so important as it follows the type of advice you would give them. So the trans-theoretical model consists of 5 different stages. The first one is the pre-contemplation. What does that mean? It means that the patient is completely not ready for any type of change, and they do not even intend to take action. It's not even crossing their mind. The second stage is what we call contemplation. In the contemplation, patient is somehow considering making a change in their behavior, not tomorrow, not in a week, but within the next 6 months. The third stage is what we call preparation. So in this stage, your patient now understands that behavior change is beneficial for me. And they have an intention to take action within the next month. So for the action stage, the fourth one, this is when your patient is currently engaged with a newer health behavior for the past 6 months. The final one is the maintenance, where your patient has sustained that health behavior change for at least 6 months without a relapse. Later on, we will tackle on the difference between relapse and lapse. So why is this really important for us? Because if I want to apply that in practice, I tell you, it is only when the patient is ready for action. That means stage number 4. Only when you sense and you assess your patient is ready for action, you start develop that specific written nutrition plan, diabetes education, whatsoever. Because if your patient is still in the 3 previous stages, whatever type of advice you're going to give is somehow pointless. But once your patient reaches that level, you need to keep in mind different things. First, you need to focus on positivity, positive things. For example, like you can ask them what you can add to your diet. Let's start by that. A very important aspect is to be realistic. If a patient comes to you and tell you, I drink 5 cups of carrot tea every day, do you expect, if you advise that patient to cut that to 0, they would wake up the next morning and before drinking it, they would think, oh, wait, Fatin told me I should drop it to 0. I think I can do it. In reality, it does not happen. We need to be realistic with the advice that we are giving our patients. And the patient also needs to be realistic in how they can implement that. It's the same currently now we are in the date palm harvest season. When a patient comes to you and telling you, I consume 50 or 60 dates per day, do you expect they will reduce it to 0 the next day? Absolutely not. So from 60, if you put a goal of 40, maybe 30, maybe for them, it will be somehow realistic. And keep in mind, the goals that you are going to base or you're going to tell your patients, it depends on their readiness to change. In other words, it depends on their confidence. Deep down inside, yes, I can do that. And their self-efficacy, how much sure they are that, yes, I can do this new behavior. Another big challenge when it comes to diabetes management is physical activity, whenever we discuss it with our patients. Physical inactivity, meaning that getting 0 minutes per day, is unfortunately the 4th leading risk factor for global mortality. Again, as I said, simplify things, it is the same for physical activity. Simple rule. We want our patients to focus on the cardiovascular part and we want them to move their muscles. So my advice, I usually tell them for someone who hasn't been exercising for a longer period, I tell them move your way. Pick the type of exercise that you love the most, that you enjoy the most, that you feel you will continue doing it every day. But yes, we still want them to do at least 150 minutes per week, combined with at least 2 days a week of muscle strengthening activity. But someone would come to you, I cannot do that. Even for them, if they would start by only 5 minutes, it's better than nothing. Focus on do what you can. We can also encourage them by simply starting by walking. That if you start to walk, for example, around 30 minutes per day, you are literally adding healthy life to you. You are literally gaining healthy lives. And the more you walk, the better it is for you. Now, a lot of people would tell you, I don't have time, I'm busy, I cannot join the gym. Excuses never end. You would come back on them and tell them, I only need 1 minute from your day. 60 seconds. This randomized controlled crossover trial proved that 1 minute to 3 minutes of stair climbing or brisk walking or simply moving your body can have and can improve the post-meal glucose handling. So when you simplify it to them and tell them, do you have 1 minute per day? 1 to 3 minutes. Probably they will answer you, yes, I do have. So you catch it and let them start doing it. So after discussing all of these interventions, how about we apply that in practice to our lovely patients? So I want you to meet our guest for today. He's a 57 years old male. He's been diagnosed with diabetes since 2008. His first visit at DEC was in June 2020. The following comorbidities, and luckily, he was not a smoker. So he saw the doctor, and the doctor ordered the general test, and he told him to come back in 2-3 days. So he did. After blood tests, his HbA1c came out somehow in control, 7.3. He was already on the following medication. We offered a CGM, but back then he refused. He said, I think I'm doing fine. I know how to manage it. I would just stick to the finger prick, and I would see you in 3 to 4 months. Patient was dismissed, and then he came back to us after 3 to 4 months, but with a whole different scenario. His HbA1c increased from 7.3 to 10.3. We don't know why it increased. The doctor offered to change his medication, but still, he said, I'm fine with whatever I have. I will try my best. I will diet. I will exercise. But thankfully, he agreed to use or to start to use a CGM. So we inserted it to him, and we told him to come back in a couple of weeks to have a look at least what is really happening inside of your body. So he did. And this was his first AGP report ever. The first thing that he would see. For him, it was an eye-opener to see how his blood sugar fluctuates. Earlier in the morning, post-meals, later in the evening. And still, he refused to change the medication. He insisted on dieting and exercising and to follow the regular advice. So we said, fine, we'll give you a chance and hope to see you again. So he kept his promise. From October 2020 to February 2021, his time in range almost doubled, 60%. He managed to drop his HbA1c to 7.1. Perfect. Everything seems beautiful, right? Patient was dismissed, and he stopped following up for more than a year. And then he came back to us, but with a whole different story. Look at that. His time in range dropped from 60% to 2%. In my opinion, 2% is actually equal to 0. So this patient went into a complete relapse. HbA1c again up to 9.6, almost 10%. So what do we do now? How do we start? Now it is time to plan. It is time to reassess. We don't want to double on failure. Patient already knows that he failed. He already knows he was not compliant. He came again to us for our help. So what do? We go back to the transtheoretical model of change. We reassess. Remember, that patient was in the red zone or in the red level. The action was doing very well, but he went back again to square one. Relapse happens. Patients need to understand that this is a normal part of the change process. In this stage, we don't want to double a failure. We don't want to ask what really happened. We don't want to add burden to the patients. We need to provide empathy, and nothing but empathy. And mostly we need to help them to reconnect with what really motivates them to change. So here we rethink non-compliance. We need to understand what really happened to that patient. What were the barriers for him to continue having a proper diabetes self-care? It is our job to proactively help them to overcome these barriers. So what we call relapse prevention plan. Now, relapse is somehow challenging even to talk about. Why? Because the unhealthy action now has become a whole new habit. So it has become a habit again. And it's not only a new habit, it comes coupled with different psychological implications and feeling of a failure, feeling I'm very far about my initial goal, feeling scared, feeling can I really go back to what I was? So it comes with all of these psychological implications that need to be addressed. And relapse, in some other words, it means that we need to put a new action plan for this particular patient. And remember, you as a provider, you should address the thoughts and the emotions that have arisen from the feelings of failure. So in relapse prevention, we address different things. So there is a difference between lapse and a relapse. We focus on lapses. Lapse is a small, tiny slip, a small mistake. No one patient can develop a full relapse over one night. So it happens gradually. So we ask them, when do you think a lapse happened? Under what circumstances? Were you at a wedding, at a party? With whom? Were you dining out with your friends, with your neighbors? And are you able to notice the lapse or different lapses before it even becomes a whole relapse? And even if it happens, are you confident enough to turn to someone to help you? So these questions engage the minds of the patients. You engage them in the planning itself instead of just a passive listener, and you are the only provider dictating to them what they need to do. So back to our patient. The biggest challenge for him was food, and not any particular food. It was that small biscuit, that crackers, pastries, especially during his working hours. So we have agreed that the type of food you are eating should be controlled. The amount of food also. If I am going to allow a piece of a cookie or a piece of biscuit, the amount has to be exact. And the frequency is also important. We cannot just allow this patient to keep eating on a daily basis this biscuit or these cookies and expect a change in his control of blood sugar. What I have found acceptable from patient is the positive prescriptions compared to the negative prescriptions. So if we want them to eat healthier, if we want to implement healthier stuff, we encourage them to eat more of one type of food. We want them to focus on the whole aspect of it instead of just tell them to consume less of that. The principle swapping or replacing food actually is way better than telling them you completely avoid it. The moment you tell them you are going to avoid that, they will go out from your office or clinic and buy that particular food. So in general, this positive approach is more accepted by our patients. Another aspect is I want him to move more. I want him to have a better control for his blood sugar. Now remember, this patient is coming to you from a complete relapse. So you need to put a plan all the way from the beginning. Especially when it comes to exercise, whenever that topic is brought, they would come up with a billion excuses. But we put it in a schedule and we talk about it and address it one by one. So I want you, for example, to do a physical activity. You choose which is better for you. For example, walking. Perfect. So how much can you do? How long can you do it? And how often can you do it? And every day, do you think starting by 3 to 4 times per week is good for you? And then they would tell you, I don't like to walk alone. Perfect. How about you try to walk with your neighbor, with your friend, or with your spouse? Another excuse would tell like, I don't know where to walk. Around the neighborhood, inside your house, walk from the bedroom to the living room to the kitchen, any type of movement. Patient would come to you, I can't do it early in the morning. Fine, how about you do it in the evening? So you will always see that they come up with excuses with you and you need to come up with a solution. For them to do that, they need a support system. Who can help you with that? Your spouse, your friend, your neighbor calling you. And also we need to address the biggest barrier. Why you don't walk, why you don't exercise. Mostly they would tell you, I feel tired after work, I have limited time. So we need to come up with solutions for that. So after all of that, we have gave him the chance, educated him, and told him, how about you go and you try your best to implement those changes and come back to us and see how things go. So we did. He came back with an improvement in his time in range, 47%. Now, this is your golden opportunity to grab on that. You need to celebrate that small success. You need to celebrate that new behavior. You need to celebrate that effort that he has put. You need to celebrate that he trusted you, that he listened to you. So you need to take that small success and amplify it, celebrate it with them. Even if we are still a bit far from our target, but still, remember this patient came to you with a time in range 0%. And here he is, trying his best, and here he is, 47%. So his HbA1c dropped again from 9.6 to 8.5, doing very well. In that particular visit, you need to use what we call positive psychology. You need to affirm the strength. You need to affirm the progress that the patient made. And this is the proper time to engage their minds. Don't let them be as a passive listener. So you need to have this dialogue with them. What benefits have you gained from the changes that you have made? Let them think about it, or even let them write it down. Let them see it. Ask them, have you learned from the challenges? Any challenges happened to you and how you have overcome that? Or how do you feel about your current situation? So we continue educating and we continue applying all of these interventions. Alhamdulillah, he managed in 2024 to drop his HbA1c back to 7.2. Everything seems beautiful, lovely, right? But in 2025, he came back. This time, in April, his HbA1c 8.7. In July, it's again 9.3. So what do we do now? Do I dismiss him? I tell him, look, I have given you everything. I have taught you everything. I cannot help you anymore. Absolutely not. Remember, they came back to you because they trust you. They came back to you because they need your help. They came back to you because they still feel you did not lose hope on them. HOPE, those 4 letters, makes a huge difference in the patient life. So at that time, I didn't ask about what really happened or what was the reason that you dropped or whatsoever. At that time, I focused on rebirthing, let's say, the inner self-motivation for him. Remind him about the perceived benefits of the behavior that he did. Ask him the purpose why he came back to me. What do you want to come out from this experience, let's say? Ask them if they value someone. What are the values in their lives? Why you're doing this in the first place? Does that mean anything in you? What really brings meaning for you into your life? And trust me, when your patients sense that they still believe in them, that you haven't given up on them yet, trust me, they will come back to you and surprise you big time. And he did. He came back with the best time in range ever, 65%. I remember that day very well. That patient came even dressed beautifully with a nice suit and a tie, and he was using a reader. And he was so confident the way he sat, the way he spoke, the way he handed me the reader and told me, you need to check this. At the end of this session, this was the last time I saw him because he left the country and went back home for good. Till now, I remember one sentence he told me as he was leaving my clinic. He said, thank you for not giving up on me. So in conclusion, lifestyle medicine as you have seen. It requires patient engagement and responsibility for the treatment to achieve the outcomes that we want. Because chronic disease is a progressive, long disease, treatments are also long term. Lifestyle medicine intervention, what makes it actually unique is that it is somehow inexpensive. Lifestyle practices and health habits are the most important determinants of positive health outcomes. Our aim is to improve unhealthy behaviors to make it as a foundational to effective medical care. For us to achieve that, we need two key elements. The first one is trust. Once you have established trust between you and the patient, they will keep coming back to you. The second thing, patient cannot do all of that huge change by themselves. They need a support system. They need it from us, from a multidisciplinary team. They need it from their loved ones. And even they need it from the greater community. Thank you all for listening. I'm happy to take any questions in the question and answer session.
Thank you so much, Fatin, for this fruitful presentation. As we always say, there is no size fit all, and shifting from blaming behavior to understand barrier and providing more personalized intervention that reflect patients' need and life preference are essential and can significantly improve their health outcome. So I would like to remind you all for abstract submission. The deadline, it will be on 31st August. You can scan the code and submit for your abstract. This is an excellent opportunity to share your research, clinical experience with the healthcare community. So who can participate? Anyone, diabetic educator, physician, allied health professional, dietitian, nutritionist, pharmacist. So don't miss this opportunity. Now we will move to our next and the last speaker of today. It's my pleasure to introduce Ms. Zainab Al-Abadle. Ms. Zainab, she is a senior diabetic clinical care specialist and diabetic educator department lead at Al Jalila Children's Hospital. Ms. Zainab, she is a clinical instructor at College of Medicine and Health Science at Mohammed bin Rashid University of Medicine, and she is the president of Diabetes Educator Society and the Emirates Nursing Association. Today, Ms. Zainab will take us into the exciting and rapidly evolving era of diabetes care with her presentation, Artificial Intelligence in Diabetes and Nutrition Care from CGM data to personalized care. Ms. Zainab, we are very happy to have you with us. The floor is yours.
Thank you so much, Ms. Rula, for the nice introduction. Good evening, ladies and gentlemen. I am delighted to be with you tonight in our 6th DES Voice webinar. Thank you for staying and sparing some time of your day after long duty hours to attend our webinar today. Whoever attended my talks previously knows that my talks are interactive in nature, so I will be sharing with you some bullet questions during my talk just to know your thoughts, share your ideas with me, and collect some data. As healthcare professional, we know when it comes to nutritional advice, and as illustrated nicely by Ms. Fatin, it is the most challenging aspects in diabetes care and diabetes management. And in fact, we spend a great deal of time discussing with patient carbohydrate counting, glycemic index, healthy options, and how the food might impact postprandial glucose response. But still, until today, we see many unpleasant results in our clinics, isn't it? So today I will be sharing with you a very interesting topic. In fact, I enjoyed it personally while I am preparing the slides for tonight's talk. It's about AI integration with CGM data and AI integration with, or estimation of carbohydrate counting, and how can we optimize those both technologies to move beyond a standardized way of nutritional advice to personalized nutritional advice. Those are my disclosures. By end of today's session, I hope that you understand why people respond differently to the same food, how AI can use CGM data to personalize nutrition, what does the evidence tell us about AI carbohydrate counting, which AI carb counting tool have the strongest evidence, and how can we use these technologies safely in our practice. To enable me covering those objectives, I divided my talk into 4 parts, different parts, sharing one big goal, better nutrition decisions. So keeping this overview in mind, let us start with part 1 of our journey today, AI and CGM. However, before I took you to the science or explore the science with you, I want you to think of a patient, perhaps 2 patients you have seen recently in your clinic who ate the same amount of food or the same kind of meal and delivered the same amount of insulin, had the same amount or the same insulin to carb ratio, and however, so they did everything exactly the same. However, their postprandial glycemic response was totally dramatically different. So have you ever seen 2 patients eat the same meal but have very different glucose response? Okay, so amazing. Majority of you said yes, and it's quite often. So why does this happen? Where is the gap? Where is the gap? For many, many years, we did not have enough information to answer that question. And we built our nutritional advice on a one simple basic assumption. We assumed that if 2 people consume the same amount of carbohydrate, they would have similar glucose responses. And that assumption formed the basis of carbohydrate counting, the glycemic index, and many diabetes and nutrition recommendations we relied on for decades. However, advances in continuous glucose monitoring systems have shown us that this assumption is often incorrect. If we have 2 different people and we serve them the exact same amount of carbohydrate, let us assume that this is 6 grams of carbohydrate, they will respond differently to this kind of meal. Interestingly, that if the same person ate the same meal in 2 different timings during the day, or in 2 different days, also he himself will respond differently to this kind of meal. So the problem, in fact, is not carbohydrate counting itself. The problem is assuming that carbohydrate counting alone tells us the whole story. Clearly, there is something missing from our understanding. So where can we find the missing information? To let you understand the concept behind To let you understand the concept or the reason behind the core of problem with one size fits all in nutrition, let us put everything together. Starting with what I just shared with you, standard dietary advice including carbohydrate counting and the glycemic index, that we assume that carbohydrate counting and the glycemic index affect all people the same is not correct, and what we are seeing in real life is totally different. Continuous glucose monitoring provided us or offered us with a unique view of daily glucose patterns, and the volume and the complexity of CGM data creates an opportunity and necessity for artificial intelligence and machine learning to identify patterns and generate actionable, personalized nutrition insights. And most importantly, that every individual has a unique metabolic response to food. Understanding these differences is one of the most important advances driving the future of personalized diabetes care. On top of everything, artificial intelligence can analyze large scale of glucose data, identify individual response pattern, and transform standardized nutrition advice into truly personalized nutrition recommendation based on each person's physiology. So, to tell you how AI can do that, I would break the concept down and I will start with the basics. AI needs data, and we get the data from CGM. So I would like to start with continuous glucose monitoring. Before CGM, we relied mainly on A1C and a few finger stick glucose readings each day. And those measurements told us what glucose readings were, but did not tell us how they change throughout the day. And then the evolution of CGM completely changed the game. Instead of viewing glucose reading each day, we suddenly had continuous information of glucose readings showing us how the patient is doing after meals, during activity, overnight, throughout the day, and for a tsunami of data for more than, if we can customize it, of course, 14 days, 90 days, 30 days of data. So suddenly, we had more information than ever before, incredible amount of information. It is very difficult for us clinicians to analyze them manually. So collecting data by itself was not enough. We need to understand those data. So this where artificial intelligence enters the picture and became very, very important. So how AI turns CGM data into nutrition advice? It is very easy, 4-step process. It is simple. So think of AI as a machine learning or assistant that looks for a pattern which is very complex for a human eye to detect. So first it will collect data from CGM. Then algorithm learns the person patterns. Then it predicts how person may respond to meal. And finally, it transformed those prediction to a nutrition advice. So keep it very simple. It's input, learn, predict, and advice. So instead of saying that everyone should eat exactly the same standardized way, the AI shift to saying or making the approach more personalized. So it will begin saying that based on your own glucose response, the recommendation which likely will work with you is so and so. So the concept of integration between CGM and AI is amazing. However, does it really actually work in reality? So let me share with you 2 studies which they change the field. I would like to start with this landmark trial done back in 2015 by Zivi and his colleagues. This study included 800 participants using 7 days CGM, and the aim of the study was to test whether postprandial glycemic responses vary between individuals and whether a machine learning algorithm integrating clinical dietary lifestyle, physical activity, and gut microbiome data can accurately predict personalized response, glucose responses, and guide individualized dietary recommendation. So what the author did is that they collect information from the patient, from the cohort, and they developed a machine learning to predict each person algorithm and to predict the person's postprandial glycemic response and provide the patient, the participant with personalized nutritional advice. What did they find? This algorithm or machine learning showed that people vary, people different when it comes to glucose responses to the same food, while responses within the individual were relatively reproducible. The individualized algorithm predicts glucose responses more accurately than carbohydrate counting. If you will see this graph in your right hand, it shows that they found a strong correlation between the algorithm itself and prediction of a glucose response with R value 0.68 in the main cohort, and when they validated it with the validation cohort of 100 participants, the R value came to be 0.70. So both showed a strong correlation, and this tells us that we can generalize the data. Also, they found that personalized dietary intervention based on the algorithm significantly reduced post-meal glucose responses. So they conclude that the same food does not produce the same glucose response in every individual. Combining CGM data and individual unique characteristics can enable more accurate personalized nutrition than carbohydrate counting alone. So this study showed us that the concept of integration between AI and CGM works nicely, but does it improve glycemic outcome? Let us zoom out from this one study to a meta-analysis done very recent meta-analysis in 2025. The aim of this analysis was to evaluate how AI, including integration with CGM, can support personalized lifestyle management and improve glycemic and weight outcome in diabetes care. What the author did, they did a narrative view for 21 randomized control trial articles, and they examined AI across 4 areas: risk prediction, personalized lifestyle guidance, remote monitoring, self-management, and clinical decision. What they find is interesting. They found that AI prediction tools frequently achieve more than 80% accuracy for diabetes risk and related condition. Also, they highlighted that AI-supported personalized lifestyle intervention were associated with improved glycemic control and weight reduction. They added that AI-enabled monitoring and self-management tools showed improvement in adherence and clinical outcomes. Also, they highlighted that the higher intensity intervention showed greater reduction in A1C. So when they combined CGM, AI with food tracker, A1C was reduced by 1.5%. What they did not see as significant, they did not see any significant change in BMI. There was some changes in weight reduction, but not the total BMI, cholesterol, LDL, and systolic blood pressure. Also, they found that greater benefit was when the baseline of A1C was more than or equal to 8%. And those are the cohort who needs help, isn't it? So they conclude that CGM and AI can enhance diabetes care by enabling more personalized lifestyle interventions, supporting better glycemic control, clinically meaningful A1C benefits or reduction, weight reduction, and self-management support. So far, I have introduced to you the integration of AI with CGM data and how AI can predict the postprandial glycemic control. But can we introduce AI even before the meal start to estimate carbohydrate counting? Let me ask you a question before showing you the technology and share with you the available evidence about AI powered carbohydrate counting. Do you currently recommend any AI powered carb counting app to your patients? Half of the attendees of today said yes, regularly or occasionally, and the 30% of you or 40% of you said that not yet, and I'm exploring options. For the attendees who did not find an AI app, I promise you that you will leave part 2 of today's talk at least with one peer-reviewed app or evidence app to recommend for your patients. So let us explore how AI estimates carb from a meal photo. Again, fortunately, the process is very, very simple. It begins with a photograph where the patient simply takes a picture of the meal and using their smartphones. Then the artificial intelligence identifies the food on the plate, and then the artificial intelligence estimate the portion size of the meal. And finally, it calculates the amount of carbohydrate in that meal. So it is very simple process. It happens within seconds, but of course the process is not yet perfect when it comes to the portion size, especially when there is mixed dishes, different sauces, hidden ingredients. The apps lag behind. So it is amazing again. And the next question here, does the integration or does those apps which you recommend for your patients work actually and improve diabetes outcomes? I will share with you two beautiful study done on two different apps using AI powered carbohydrate counting app. I will start with the first study called iSpy, or done on iSpy app. It is an AI powered carb counting app for youth patients with type 1 diabetes. The aim of this study was to evaluate whether AI image recognition app, the iSpy, is usable and can improve carbohydrate counting accuracy in youth with type 1 diabetes. What the author did is that they developed the app, and then they conducted a usability testing study followed by 3-month pilots RCT comparing iSpy with usual care versus usual care alone. So they recruited 44 participants. One was in the arm of using the iSpy application, and 22 was in the control group. So what did they found? How the app work? First, it is exactly how I just explained to you. The patient takes the photo, the app will estimate the carbohydrate counting or the carbohydrate estimation. Then the patient can add extra input, optional text or voice details to refine the final count. What did they found? They found that the app improved carbohydrate counting accuracy significantly with p-value 0.008. They found fewer carbohydrate counting error with meals which exceed 10 grams of carbohydrate. They found significant reduction in A1C compared with the usual care with p-value 0.3. And they found that 86% of participants found that the app is fairly to easy use. And they conclude that it is a small but carefully designed pilot randomized controlled trial. AI-assisted carbohydrate counting improved both counting accuracy and A1C over 3 months, promising study, but larger confirmatory trials are needed before wider clinical use. Did the researcher or the authors stopped here? No. This technology was revisited and upgraded. So from iSpy platform it was refined to another platform called RX Food. And they released it to the market in 2022. It is an expanded form carbohydrate estimation platform, and it is more comprehensive with AI-based meal analysis and nutrition assessment. So this study was very important because it showed that artificial intelligence could improve a skill which is many patients struggling with in everyday practice. If you want to download or look into the app, it looks like this in your app store. Moving from type 1 to youth type 1 to adult type 1. Another application was evaluated called the Snack. It is AI meal photo carb counting for adults with type 1 diabetes. The author here wanted to test whether an AI depth sensing meal photo app can accurately estimate carbohydrates and improve glucose time and range for adults with type 1 diabetes using automated insulin delivery systems, the AID. What did they do? It is a 3-week randomized controlled trial. They recruited 44 participants. 22 of the cohort were given the opportunity to use the Snack app versus 22 who continue doing the usual care. They tested 48 meals counting with 128 food items, including breakfast, cooked meals, and snacks. They used iPhone X with belt leather depth sensor, and the actual food weight measured was used a precision scale served as a reference for the food weight suggested by the app. So what did they find? They found that there was a mean absolute error by 5.5 gram in the carbohydrate estimation of the app, and this is equivalent to 14.8%. They found that only 7 of 128 food items required manual correction. They found that the average carbohydrate estimation process time was about or less than 22.9 seconds. The accuracy was not significantly affected by the angle of the photograph or the light of the phone. Snack cohort got significant higher time in range and lower mean glucose with no changes in insulin doses or carbohydrate entry. The app is amazing and it's very promising, but it has some limitation. They found that snack app appeared more accurate than patients' own estimation, but however, this differences was not statistically significant. They found that glycemic benefit did not persist, unfortunately, and when they discontinued the app, the benefit was faded. Also, they found that user accepted snack exact carb suggestion only 19% of the time. So they had a trust issues with the app, and this is normal with any new technology. So they conclude that a 3-week randomized controlled trial found snack app meaningfully improved time and range for AI users, but the benefit faded after stopping using the app. And they found that the accuracy edge over patients themselves was not statistically significant. If you want to look into the app, this is how it looks in your app store. Each photograph will be broken down to different meal items with the weight of the item, and it was mapped against user glucose response. So if you wanted to suggest or recommend an AI-powered carbohydrate counting app to your patients, what matters the most with you? Is it the accuracy, easy of use, clinical validation, or CGM integration? Okay, in fact, all options matters, and it is not easy to suggest an app for your patient. The majority of you chose accuracy and easy of use. I support both answers. It should be accurate and easy for use, so it will ensure sustainability and improve the outcomes of patients' glycemic control. So it's not easy to choose an app, and I will help you to make the right decision. When it comes to AI carb counting apps, we categorize them in 3 different categories. The first category is tier 1 category for the apps which are supported with robust clinical trial and demonstrate data of patient benefits. Tier 2 are for the apps which hold independent technical accuracy validation with no published evidence of improved glycemic outcomes. Tier 3 is a commercial app with limited or no independent peer review evidence. So let me show you or share with you what each category apps listed under each category. Starting with tier 1, it is the 2 apps which are apps which I just shared with you, the snack app and the iSpy food app, and those are the only 2 apps which they have evidence behind their use. I wanted to highlight here, I won't go through advantages and disadvantages of each app. You can read them later by your own because of the sake of the time. However, I want to mention that the snack app is not free. The patient can try it for 7 days, and then if they want to continue using the app, they have to pay. When it comes to the iSpy food, which is the RX food now, it is free in USA and through healthcare professional. So it is not unfortunately available in our country unless you change your phone settings location to USA. In tier 2, we have 2 applications. We have MyNet Diary and we have Food Advisor. Those they might be useful for the patient for food tracking and for meal recognition, but you need to remember that there is no publication evidence behind those apps, and however, they are available for patient and they are easy to use. When it comes to MyNet Diary app, it is the only completely free app for patients. And when it comes to the Food Advisor or a Food Advisor, it is freemium. So the patient can download the app, they can navigate through the app, but there is in-app purchase item. Tier 3, we have 3 apps listed under this category: Carb Manager, Dexcom G7 Smart Food Log, and BiteSight. The Carb Manager, again, it is a freemium. The Dexcom G7 app, it is free for customers who use Dexcom G7. However, unfortunately, this feature in the Dexcom G7 we have in Gulf countries are disabled, but it works nicely in USA. I would like to highlight the Byteside application. The Byteside application, it's not a free app. Again, the app will give you only 7 days trial and you need to pay if you want to use the app. However, this app has regional perspective. It includes all our Gulf cuisine food in this app. And why is that? Because this app was built by a person with type 1 diabetes called Safe, and he is from Qatar. He is a solo AI engineer who has lived with diabetes, and he built this app by his own. It is very lovely app. I downloaded it and I went through it. However, you need to remember that those apps still limited for evidence and publication. So I have shared with you the how AI can be integrated with CGM and with carbohydrate counting and what apps are available in the market. Now we will move to our clinical practice, which concerns most of you, and I wanted to explore what does this matter for clinicians, for patients, and for public health, and where the real barriers still sit. I am lovely lady. I'm not at all negative. However, I will start part 3 with the barriers. I want to hear your thought. Where do you think patients may face the biggest barrier to use these tools? Is it the cost of device? Is it insulin dosing, benefit that may not persist, or data privacy? Interesting. So majority of you chose the cost of device. However, in fact, all those are barriers. So let us move from excitement. Applications are excited. They have a lot of excitement. They are amazing. However, this kind of technology still have important limitation. I grouped my limitation to a technical accuracy. Still, we have issues with the accuracy, specifically when for the portion size estimation, mixed dishes, lightening, local food, all can affect the accuracy and worsen the results. When it comes to insulin dosing, most of apps stop short of recommending insulin doses for patients. When it comes to the benefits which may not persist, this was evident and showed by SNAC randomized controlled trial. In fact, the glycemic improvement did not sustain, and the benefits faded when the users stopped using the app. When it comes to border systemic challenges, still we have challenges around validation and generalizability. We need long-term randomized control trial and model to train one population which might not transfer to others. So we need to generalize the data and we need to do research in different population, because what we have so far is on type 1 diabetes, pediatric and adult, but never tested in other population. Still, we have concerns when it comes to data privacy about storage, consent, and third-party access. Cost, as every one of you chose, it is an issue, and those applications are expensive in many settings. So I will conclude this slide with balanced perspective. I would say that some research showed that patients with diabetes can do fine without perfect carbohydrate counting. Lots of our patients do carbohydrate counting, but not perfectly well. So those tools can be used as a support tool and as a support technology, not a strict replacement for healthcare teams. Still, clinicians provide the context, the experience, and the advice. So if you wanted to use this technology as a support and you want to provide it to your patient, where do you see the biggest opportunity and support for AI in your own practice? Is it patient education? Is it reducing burden, personalized therapy, or closing equity gaps? Okay, amazing. So most of you chose patient education, and actually all those benefits are interrelated. So if your patient is educated, it will reduce the burden, and when the patient integrate with the system, this will give more personalized therapy to and more personalized approach. So what can we add when it comes to a clinical application in our own practice? So IA AI, should not replace diabetes educators or dietitian or nurses or physician, as I just mentioned to you. It should give every patient advice, and it should help us to move from our traditional way to more personalized way. Still patient needs educator, still patient need the physician, they need the reassurance, they still need someone to explain the recommendation and the sense behind those recommendations. So that is something AI cannot replace. And when it comes to public health and policy, this is equally important. We must explain for the patient every limitation, and we should be honest with the patient. From public health perspective, we also need policies that ensure that those technologies remain accessible, affordable, and appropriately regulated among our patients. So reaching to our fourth part of today's session, which is the future direction, where the technology, the research, and the tools are heading next. So we have seen AI in integration with CGM, AI in integration with carbohydrate counting skills. However, we saw those two features separately. The AI future integration should treat CGM data and carbohydrate counting as one loop. The future is not about separate AI tools for CGM and carbohydrate counting. The researchers and scientists should bring them together in one connected, continuously learning loop. Still, we need to have a meal photo feeds carb estimation and portion size, which is linked automatically to CGM data, which adds a real glucose context, recent trends, and time and range. And the AI will use both features together to personalized AI prediction, and will combine the meal data with the past responses, current responses, activity of daily living, sleep pattern, and insulin inboard to generalize and transform all those data all together to a real-time recommendation. Not only that, it is continuous learning. So every meal should refine the next glucose prediction and generalize and advise accordingly. So the future is not just a smarter AI, it is a continued AI where the meal, the glucose response, the recommendation all become part of one continuous learning loop. I would delightfully share with you our contribution to this space. We are in a phase of conducting a randomized controlled trial to assess the visibility and effectiveness of an AI-powered carbohydrate counting educational platform to support here the parents of children with type 1 diabetes, and we called our app Carby AI. The app got registered as a randomized controlled trial in clinicaltrial.gov, and we are about to start collecting the data. So stay tuned. Maybe next year I will have some data to share with you. This brings me to last slide of my today's talk is the key takeaway messages, and I can leave you with those messages. The same meal can affect two people very differently. Generally, carb counting advice has real limits. AI helps in two ways: predicting glucose responses from CGM data and reading carb from a meal photo. The strongest evidence I spy and snack shows real benefit, but real world error still exists. App quality varies widely. Always check whether a tool has a published trial behind it or not. Finally, these tools work best as a decision support alongside good clinical judgment, education, and equity awareness. This brings me to the end of my presentation today. Thank you, and I am open to take any questions.
Thank you, Zainab, for this informative and excellent presentation on artificial intelligence in diabetes and nutrition care. So AI becoming an essential part of healthcare, and it's important to remember AI should support, not replace clinical judgment. So now we will move to the panel discussion. We will open the floor for the question and discussion. I would like to invite all the speakers. So first question for today, what is the scope of using CGM for some time in a pre-diabetes as a preventive tool? Dr. Al-Amin?
It seems to me. Yeah. Thank you very much, Ms. Rola. This is a very important question. However, the answer should be deferred to a couple of years down the line. Yes, there are a couple of studies conducted in pre-diabetes era using the continuous glucose monitoring to better understand the biology, to enhance and empower the behavioral changes. But there is no long-term outcome that confirms that using CGMS might defer or delay occurrence of type 2 diabetes. This is a pretty premature section or sort of evidence area. No currently any professional society guidelines that recommends using CGMS in pre-diabetes phase. We are just got excited by endorsing the CGMS in early type 2 diabetes or type 2 diabetes off insulin. Probably we need to wait for a couple of years down the line to get it on board for behavioral changes, knowing the biology, the body reaction to certain type of food, body reaction to physical exercise, sort of on time rewarding reports when the patient gets exercise, like Ms. Fatin mentioned, that the rewarding system is highly valued and important in any lifestyle intervention. As of now, I don't think it will be available in any institution or any guidelines might recommend it because of the scarcity of evidence. However, many patients are buying those CGMs from over the counter, and we can support them by the education and follow-up. However, not yet recommended, and this might need some time to be a solid recommendation.
Okay, one more question. What is your advice to doctor who continue recommending sliding scale in managing diabetes patients?
Okay, so should I jump in? Okay, so this is an ongoing dilemma in the in-hospital management of diabetes, and we sometimes understand an on-call doctor he gets an admission at 3 o'clock in the morning or 4 o'clock in the morning. He has very limited mental stamina to calculate the daily dose or to put the correction doses. However, the standard is to have fixed doses with correction based on the calculation of the insulin needed. But practically speaking, we have moved a very long way from struggling to have a single patient on fixed dose insulinization with a correction versus the amount of patients admitted on sliding scale to only few patients now are on sliding scale in hospital service. So we are getting there. Probably education will solve this problem.
Thank you so much, Dr. Amin. One more question. Do we currently have enough evidence that combining AI with CGM improves long-term clinical outcomes, such as HbA1c and diabetes complication, or is the evidence mainly focused on improving time in range?
In fact, as I just discussed, that there is no long-term randomized control trial was conducted in this regard. However, there is one trial showed that discontinuation of the use makes the benefits fade. So we need more research in this field to answer this question. The answer is no. We don't have any yet study done in this regards.
Okay, excellent. Question, I think, for Faten. Is CGM data alone sufficient to provide accuracy or accurate dietary recommendation, or should AI also integrate factors such as physical activity and sleep and body weight and medication?
I think from our current practice, we can rely on the current CGM data to provide somehow different approaches to the nutrition plan. Ideally, yes, I would love to see in the near future AI combining all the factors that truly affects the blood sugar and giving us a better insight on for the nutrition plan to be amplified. But from the current practice, having the CGM data alone, you can easily pinpoint what are the reasons that can cause hyperglycemia when it comes to food itself.
And I want to add that Ms. Fatin showed in her presentation that there are 42 factors that might affect glycemic response. So if the patient, in every CGM, there is a note feature. So if the patient can add what is happening around the patient, it will make the picture more colorful, and it will add more data. So it is better when we have a clearer, bigger picture. It helps us a lot in giving the advice. Sometimes, maybe if Ms. Fatin, maybe I'm not sure if you will agree with me, but I ask the patient, what did you eat on this day, like 10 days back? The patient will forget. They can't remember what did they eat. So I always tell them, if you don't remember, I want to see the notes entered and integrated with CGM data. And believe me, this is a game changer when you have a full, complete report with all factors, even exercise. They can add and put any activity they do along with CGM data. And this makes it very easy for us as a clinician to make the decision in less than minutes.
Okay, is the follow-up times with educator in the clinic will change as previously standard because of AI support?
No. As I said, it is only support. It doesn't replace us. So still patient needs to see educators and see physician to take the right advice and to understand and get reflection of those recommendations.
Yes, nutrition decision remain the lead or professional. So do we currently have enough evidence that combining AI with CGM? I think we answered this question. Okay, yeah. So how can we ensure that AI gives safe and reliable nutrition advice?
I would answer, and maybe hear from Ms. Fatin as well. In fact, before introducing AI to the patient needs to be well educated about the targets, about how the patient needs to interact with the data. So the well-educated patient will know and can identify whether the recommendation fits him or not. So education is the basics. They need to have education always. And with education, I think we have to equip them with skills to make them able for decision making, because I always say that they will live with diabetes 24 hours, 7 days a week, 360 days a year. They see us only less than 1 hour in the clinic. So they have to take charge of their health, and they have to make informed decision about their health, and they need to know whether the app is accurate or not. They decide more than us.
Yes, true. Okay, a question for Ms. Fatin. In your experience, what is the biggest barrier to sustainable lifestyle changes, and what is one practical strategies can use to overcome?
The barriers, it's not only one barrier, maybe 100 barriers. It's so difficult from my current practice to convince someone to change, to change the way they think, to change the way they eat, the way they sleep, despite knowing that this current behavior is harmful for them. They still continue doing it. For many reasons, we have a lot of barriers. Maybe the lack of education, maybe the patient is not ready, maybe the lack of the support, maybe the cost, the financial status, many different barriers. I cannot just answer it like by just addressing one barrier, but I can assure you that the regular follow-ups with the educators, with the dietitians, and perhaps also with the physicians, you cannot have a result from 1 or 2 or 3 sessions. The regular engagement, regular patient coming to follow-ups will help them in changing their current behavior only if they want to. You can spend years educating specific type of patients, and every time they come to your clinic with the same time and range, nothing has changed. At the end, you need to understand that we cannot force people to change. We occupy them with the tools and and stuff that they need to, and you leave the decision to them, simply.
Thank you. Thank you so much, Fatin, for your answer. And unfortunately, we are running out of time, and we came to the end of today's webinar. I would like to sincerely thank all our speakers for sharing their practical insights and experience with us today. It was a great and fruitful discussion. Thank you so much, Dr. Al-Amin. Thank you, Ms. Zainab, and thank you, Ms.
Thank
Fatin.
you, Rilla.
Thank
Thank you
you
so
for
much.
all the participants who are joining us today. We truly appreciate your time, participation, and I hope you found it informative and useful. So please scan the QR code to submit your feedback. And finally, I would like to thank the sponsor for today's webinar about diabetes care and the Choice for organizing today's event. Thank you so much for their support. And also, don't miss the opportunity to register for second Emirates Diabetes Educator Society conference that will be starting in 31st October and the 1st of November for 2 days. And we invite you to register and joining us for 2 days of activities and valuable conference. For registration, so please, you can scan the code and register. And also, don't forget to submit the abstracts. The deadline for submitting the abstract will be 31st October, 31st August. Also, we look forward to seeing you again. We have many more webinars coming up by Diabetic Educator Society Voice. Thank you so much and wish you a wonderful evening.
Thank you. Have a great
Thank you
day, everyone.
everyone.
Thank you
مع
so much.
السلامة.
Thank you.